Yes, sir. You can see it.
Yes, sir.
Okay. So we are going to cover survival analysis using one of the methods called Kaplan-Meier curve, which is the most popular method. So what I want to do is just share with you why and when we do need survival analysis, what is an event, what is censoring, what are the principles and calculation or technically called estimation of survival curve, what are the assumptions and what are the pitfalls. So you use survival curve when it is not only the fact of occurrence of an event which is important, but also the time before it occurs is important. For example, if you are treating patients of asthma coming to emergency, you give injection, people improve, go back home, you don't need a survival curve. But if you are treating patients, for example, of cancer, where you know that it will take long time before you will know whether your chemotherapy had an effect or people survived or didn't survive, they survived without progression, with progression. So time becomes very important. So wherever time is important, survival analysis is necessary. But please don't go with the idea that when things happen within a day or two, it means survival analysis is not necessary. There are some situations where it may be necessary. For example, we use survival analysis to find out time to do CT scan after the patient of suspected stroke comes to the emergency. Now, it has some advantages, that is why we do it. But whenever time is important, and it is very important to know how much time it takes to get CT scan done after the patient reaches the door of the an institution or hospital. So door to CT time is one of the very important consideration when you evaluate quality of stroke care. So since time is important, we can use survival analysis even though CT scan is usually done within few hours. So the issue is that whenever time is important consideration, you have to use it. In trials of antidepressant, investigators are not only interested in remission. People will get remission. But every now and then new antidepressant comes and they claim that remission is coming faster in our product, which means it occurs sooner than it occurs with the standard medicine. So time to remission becomes a relevant outcome. So that is the situation when you will use survival analysis. It is also called time to event analysis. And since in the beginning when survival analysis started, this event used to be death. So time to death means you are surviving till that time. That is why probably they called it survival analysis. But nothing to do with really survival or death. Any event, wherever time is important for you, time to event analysis can be done. The other word for time to event analysis is survival analysis, but it is not only analysis of survival which is done. So why we need survival analysis? First thing is, whenever there is censoring. What is censoring? Censoring means patients or study subjects, I should say. You can, people who are in medical education, they can also use survival analysis, time to clear an exam or whatever, time to finish your thesis. All these things are amenable to survival analysis. But if event is not observed, which means your subject or study subject goes out of the study before event occurs. Why will anybody go out of the study before event occurs? Because the study stops. So you can't carry on study till everybody has got an event, for example, death. Therefore, your study stops somewhere where censoring of all people who have not had the event happens. And this, one of the very important thing is, that you know that people enter study at different times. You started the study today. Let's say you are doing a study on COVID or HIV or whatever. Every patient, or your whole sample size of, let's say, 200, is not present at your door on day one. You will recruit one patient today, two patients tomorrow, maybe five patients after a month. So they come at different times. But your study funding is for, let's say, 3 years. So you stop your study at 3 years, but you know that people have been coming. Some people came 6 months after start of study. Some people may have entered 1 year after the study. So those who entered 1 year after the start of the study, their survival or follow-up time was only 2 years. But the person who entered on day one, the follow-up time is 3 years. So whenever there is unequal, which is very common in clinical studies, you do survival analysis. So I have already said that time which a study subject takes to meet an endpoint, and that endpoint, if dichotomous, is an event, called an event, beginning from some predetermined starting point. Now, what is the starting point? It depends on the study. I will come to that later on. But example of time to event is, I've already said that, but more concrete examples will be time to death, time to recurrence. For example, in cases of epilepsy or multiple sclerosis, time to relapse, time to relief of pain. All of these can be time to event data or survival analysis. It's also called failure time data, because failure is an event, and that was another commonly used data. So failure time data is also same as time to event data. I have also told you that losses to follow up, different lengths of follow up, is something which can be dealt with very efficiently if you use survival analysis. Now we come to the term censoring. Now, censoring are many types. One, of course, I have already said that whenever you stop following up anybody before the end point of interest occurs, that is called censoring. Usually it is because of study loss to follow up. Patients stop coming or stop picking up your phone, or they change their phone, or they are not contactable, they don't come for follow up visits, or the study closes. I've already said that if study closes, that is also you can say a type of loss to follow up or censoring. Another event may occur. So, for example, if you have patients of HIV, or let's say seropositive HIV, you are following up. Some people meets an accident and dies. That is an unrelated event. So, if unrelated event occurs, then at least further follow-up of that individual is irrelevant, or there is also possibility that somebody who is actually being followed up after MI suddenly develops a stroke, and you are not interested to follow up further, or if it becomes irrelevant, then also you will censor that subject from that point of time. Now, I told you starting time is very important. When should we start counting the time? In epidemiology, people start, for example, from birth date, or whenever there is a cohort and you start baseline assessment, you do it on whatever day, that is the starting day. In clinical studies, you can do it from date of surgery, for example. It should be well-defined time. It can be start of treatment, and of course you will know when you are starting the treatment. If you are doing randomized trials, then date of randomization will be another very good start time. Now, whatever start time you take, it should be justifiable for the research question. That's the most important thing. Now, as I told you, there are many methods of survival analysis. Some are parametric method, which we will not cover, but one very popular non-parametric method, Kaplan-Meier, which we are going to cover, And there is a semi-parametric method which is used for multivariable analysis, which is called Cox regression, which will not be covered today, we'll cover sometime later. Now, here one more concept is very important to know, and that is the concept of risk and conditional risk. So, risk of having an event, for example. So, let's say you are following up 100 patients for a fixed period of 3 months. So, easy to handle. And in the first month, 40 people die. Second month, 20 people die. And third month, 10 people die. So the risk of death during first month, second month, third month will be calculated by the denominator 100 because you started with 100 patients. 40% died in the first month, 20% died in the second month, and 10% died in the third month. So 40 out of 100, 40%, 20 out of 100, 20%, 10 out of 100, 10%. So that is what is risk. But when you talk about conditional risk, then we talk about a risk of death in a time interval given, which is called technically as conditional, upon a subject having survived the beginning of that interval. So remember, for each interval, you look at the beginning, how many people you are starting with. And so first month, you started with 100 people, 40 died, and therefore 40 upon 100, 40% is, as you can see, risk also, conditional risk also. But second month, because 40 people died in the first month, only 60 people are remaining. So conditional upon surviving first month, there are 60 people and 20 died. So 20 out of 60 becomes the conditional risk, which is 33%. And in the third month, now how many people are remaining? 40 have died in the first month, 20 have died in the second month, 60 people have died. So we are left with only 40 people. So out of 40 people, third month, 10 people died, which is 25%. So in the third month, conditional risk is 25%. So please differentiate between risk and conditional risk. Same thing will happen on the reverse. We are talking about death, but if you are talking about survival, same situation will happen. There will be survival and there will be conditional survival. Why are we talking about this? Because the whole Kaplan-Meier curve is made on conditional survival. It is a survival curve, but it counts how many people were there in the beginning and how many people had event during the interval of interest. So it is a conditional probability. That's why we always, you have to keep that distinction in mind. So again, to repeat, risk was 40% in the first month, yes, also in the conditional risk. But risk was 20% in the second month, but 33% if you take conditional risk. Risk was 10% in the third month, but conditional risk was 25%. So that is the difference. Denominator is different. Now, most of the time, you know that patients enter your study at different times. So some people start in the day 1, some people come at day 10, some people come at day, maybe 300, and some people may come at the 2 years time. So different people come at different times. Then X means event. They have event also at different times. So some, which is the lowest line, you see this patient entered the study almost after 50% of the time was crossed and then had an event very quickly, unlike the yellow line where person survived for long time. This is the real scenario. But when we have to do survival analysis, first thing we have to do is we have to pull back everybody starting to the y-axis, which means as if everybody started at the same time. So that is why it is better to use the word estimation. It is not the actual thing. There is some hypothetical situation which we do. If everybody had started at the same time, then what would have happened? So that is the hypothetical part of survival curve. Second thing we do is we arrange them in order like this. So the person who was followed up for highest length of time, as you can see, is at the end, and the person who had the shortest follow-up is at the top. So the arrangement also is not according to the time when people entered. This person depicted by yellow line actually came at the very beginning of the study, but he survived very long, and perhaps the longest survival. And that's why it comes at the. So there is a hypothetical thing which you have to do, and you have to arrange it that way so that you can get a table like this. Suppose, and I'm going to take only 5 days follow up to make it easy for you to understand. So 4 patients with brain hemorrhage, they were followed up for 5 days. As you can see, 1 each died on the 2nd day and 4th day, and 1 each left against medical advice, not unusual thing, on 3rd day and 5th day. So this is what is the scenario, easy to follow. Now think about it. Day 1, we started with 4 persons. Nobody died. Nobody lost to follow up. So proportion died 0, proportion surviving 100%. Therefore, when we say cumulative survival, we go on accumulating. So there is no question of cumulative. Now it is just the starting, which is also 100%. Now day 2, out of these 4 patients, 1 died. Nobody was lost to follow up. 25% died. 1 out of 4 died. So how many survived? 75%. So cumulative survival will be 1 multiplied by 0.75, which is 0.75. So cumulative will multiply the first one and the second one, and second one and the third one, like that it will go on. Now day 3, nobody died, but 1 left against medical advice. Now he did not die, so proportion died is still 0%. Surviving this period, which is what conditional survival you can say, is 100%, right? Nobody died. All 3 are surviving, though 1 left the study. Leaving the study is censoring, it's not having event. So I have already told you that. Therefore, cumulative survival still remains 0.75 into 1, which is 75%. Now day 4, as now you can see, out of 4 people, 1 has died, 1 left against medical advice. We are left with only 2 people. Now 2 people, out of 2 people, 1 died, which is proportion dying is 50%. Nobody was lost to follow up. 50% died. So surviving this period is 1 upon 2, which is 50%. Now the cumulative survival will be cumulative survival on day 3, which is 0.75 multiplied by 0.5. So that will come somewhere to 0.38, 38%. On day 5, now we have only 1 patient. Out of 4, 1 has died, 1 has left, 2 have died, and 1 has left. We are left with only 1 patient. That patient is lost to follow-up. That doesn't mean anybody died. He didn't die. So proportion surviving is still 100% in this period. So the cumulative survival becomes 0.38 into 1, which is 38%. The whole curve is made on the basis of cumulative survival and the time period, which is on the x-axis. So you can see day 1, day 2, day 3, day 4, day 5. Of course, up to day 2, everybody was surviving, so that is 100%. But 1 person dies, so 1 step down, and that was our cumulative survival, which is continuing up to day 4. You can see here. You see, before the beginning of 4, we are 0.75. Then we become 0.38. So you can see it goes to 0.38. And that is what remains. Even 1 person left against medical advice, but that doesn't mean he died. So the curve remains here. So you can see every time step is only when patient dies.
Dr.
Now,
Sunil Narayan has a question, sir.
yes, Dr. Sunil Narayan.
I'm just wondering,
Yes.
so is there an assumption that every person who leaves is considered as not dead? So
I will come to that. I will come to that. There are so many assumptions. I will come to that. But just going through how a survival curve is made, and each survival curve you make has a confidence interval around it. So remember, this survival curve is what you observe. But if you want to extrapolate to population, then you have to keep in mind that around that curve there is a confidence interval. Now, I've already told you censoring occurs because of loss to follow-up or because the study closes. There are many types of censoring, left censoring, right censoring, and so on. But I'm not going into those nitty-gritty, and it is unnecessary also for clinicians. If you remember these two common causes of censoring, that's good enough. So what are the assumptions? Dr. Sunil Narayan started with that. It says at any time point, censored study subjects, let's say, they are having the same survival prospect as those who are continued to be followed up. So remember, we don't know what happened to them, but we are assuming that survival prospect of those who left is same as those who are within the study. And this is applying for at every time. Survival probability are the same for subjects recruited into the study at different times. That is another very important assumption, that you may have 5-year study. Now survival probability of year 1 people and year 5 people is supposed to be same. So Dr. Puri, I will send you the slides. So don't worry about annotating. Otherwise, it gets fixed. Survival probability are the same for subjects recruited into the study at different times: year 1, year 2, year 3, year 4, year 5. And it is also assumed that you know the date of event. Events happen at the times specified. Now, this is very important because if you want to use survival curve, you must know the date of death. So I can tell you, we were doing TB meningitis study. Many people died in their juggies, and when we went and asked people when did they die, people were not able to even recollect because the whole family had went to Bihar, and therefore the person who is the neighbor, he doesn't know exact date when he died. Very difficult to make survival analysis in that kind of data. You must know the specific date of death or date of the event, if it is any event, before you can have. There are other assumptions also, I will come to that. So I think it got fixed again. So when is Kaplan-Meier analysis not valid? And that is when the assumptions are violated. If censored subjects are dissimilar to those who are continuing to be followed up, which means they have different survival prospect, they have different survival probability as compared to those who continue, then it is not a valid analysis. Unfortunately, we can't check it, so we don't even know how many of the Kaplan-Meier curve which we see are really valid, but this is an underlying assumption. If there are too many censored subjects in the period of interest, then of course also it becomes questionable. If your sample size is very small, like I told you in my example, with that kind of data, only 4 patients, Kaplan-Meier analysis is not valid. You need reasonably good sample size, otherwise the whole X and Y axis will be covered by the confidence interval. So you need reasonable sample size. Large time intervals occurring between consecutive events is also not a very good thing for valid Kaplan-Meier analysis. So these are some of the things which you ought to know. Let me take some examples to make things clear. Now this is one example. Now this is an example to show that there is a confidence interval around every survival analysis. And as you can see, the circles which you see, circles are people when they are being censored. But whenever a person dies or has the event, then there is a step. So step means there is certainly event, and these circles, some people denote it by small line, but that those are the censored people. Since towards the end of the study, you can see a lot of censored people because they may have either left the study, they didn't have the event. Most people left it towards the end, and that is what will happen in any study. Another important thing to note is that number at risk is given at the bottom. This you must check in every survival curve. If they are not giving it, this is very poor way of presenting survival curve. There should be number at risk and number of events in the bracket. So you can see that you have the number of events in the parenthesis and number at risk. Now, a survival curve may be something like this. If you have time in days which goes into hundreds, then obviously towards the end of the study, everybody, remember, everybody did not enter in the same day. So some people are censored very early because the study closes after that much period of time. So this study, which was our basically 1 year follow-up study, after 365 days, you can see a lot of censoring because these people were completing their follow-up period or the study closed at that time. Number at risk is given at the bottom. You can also give number of events, but that may be clear from the number of steps also. But you must give at least the number at risk. You can see that number becomes smaller towards the end, and reasonably so, because obviously very few people have been followed up for means entered early and survived as well. So when their numbers are small, then that part of the survival curve is not very reliable. Another thing I wanted to say is survival curve need not be from above downwards. It can be from below upwards also. So for example, here this is for hepatitis B, and it is time to reactivation. So obviously nobody had reactivation in the beginning. Then some people have it and goes on with time, it goes on increasing. The number of people who had reactivation goes on increasing. So you can have survival curve which looks from below upwards, whereas most survival curves, because they are people are not having event. Event is something which is occurring after some period of time. Then all are denoted as free of event, and then you can probably have downward trend. So you can do it both ways, and there is nothing wrong in whichever way you present the data. Now, in any survival curve, you should be, if there is at least 50% people are surviving during the observation period, then you can calculate the median survival time. So median survival time, in this case, you draw a line where 0.5 is there, 50%, draw a line wherever the curve is touching it, then draw a line vertical and find out what is the number of days. So let's say in this case 240 days or so. That is the median time of survival. If people don't survive, 50% means people don't, your curve does not reach up to 50%, then you can't calculate median survival time. But most of the time you can. Now, if you have to compare two survival curves, then what do? Usually they use what is called log rank test. Now, I'm not going into what log rank test does because that is happening inside the computer. But the null hypothesis is that there is no difference in survival between the two curves. So basically, they are overlapping. Means if you had confidence interval, you will find they are touching. But you just by eyeballing, you cannot always pick up whether there is significant difference in survival or not. So you have to have a p-value. If the p-value is less than 0.05 most of the time, it is inferred that population represented by the two curves have statistically significant difference in survival. Now, that may be clinically important, may not be clinically important, but that is what the log rank test tells us. I will repeat again. Assumptions are the probability that a person is censored is uniform, means, sorry, I can't read it here. The probability that a person is censored is similar to the person who suffers an event. That means I have told you censored subjects have the same survival prospects as those who continue to be followed up. Now I told you that this is very difficult to test because you don't have any data to test this, and particularly in cancer probably it is not valid, but that is where most of the survival curves are. So I told you we don't know how many survival curves really meet these assumptions. The other thing is that hazard ratio between the two groups remains constant over time. I will talk about hazard ratio next time, so I will leave it at this point. But that is another thing that will be visible in the curve if they don't cross each other. I will show you one curve which crosses each other, in which case it is hazard ratio is not constant, then that will be a problem. But we will discuss hazard ratio next time. Now, another thing is survival prospect of patients who came early and those who came late is also similar. This is what is another assumption. And certainly if treatment is modified, then it is not valid because line of treatment differs, then maybe survival probability also differs. So you can't have survival analysis going on for 10 years when a lot of different treatments are coming. And certainly that will violate this assumption that I have alluded to earlier also. The other assumption is that I have told you that events happen exact at the time specified. Now, it won't be valid if patients are called at every fixed intervals. You call them every 3 months, you call them every 6 months. So I was facing this problem when we said time to recovery, and recovery we defined in one of our study as achieving MRS of 2 or less. Now, when did the patient achieve MRS 2 is you don't know because patients are coming after 3 months or so. If you ask them, when did you start walking independently? They will give you a very rough idea, maybe in this month, maybe in this week, but you don't know the exact time. That type of data, you can't use valid Kaplan-Meier analysis. Another situation where Kaplan-Meier analysis has limitation is if censoring is more than 50%. Don't believe that type of survival data, at least not the period where there is more than 50% censoring. The period where there is less censoring is valid and you can trust that survival curve, but not after a lot of people have been censored. And another thing is, these economists, what they do is when they do cost effectiveness, they extrapolate beyond the curve. And sometimes they will say, oh, maybe I should assume that curves remain parallel after this. So a lot of assumptions come. But actually, after beyond the curve, extrapolation is not really correct and it's not valid. I have already said that if very few subjects are there towards the end, then end of the curve is not valid and those estimates are imprecise. And I also told you median survival time is possible to know only if 50% people have experienced the event. If the curve does not reach up to 50%, you can't really get the median time, median survival. Let's say as time progresses and very few patients remain in your survival analysis, then there are two things. One is interval between the event will grow because very few people are there. And also the effect of each event or each failure on size of the step will increase because if there are only 2 people, 1 person dies, 50% drop. So you can see there is big drop in the size of step. But as you can see, that will visually magnify your impression, but that is not correct. So you have to keep in mind towards the end, not to give much importance to those that part of the survival curve. Now, if there is only one patient remaining and that person, let's say, dies, if death is the event, then the Kaplan-Meier survival will drop to 0. But actually, if you are thinking about a population, then it never reaches 0. So you should keep that in mind, that that is another limitation. I think we have talked about these limitations, but there is one more limitation which we need to keep in mind, that Kaplan-Meier calculations will remain unchanged if patients are censored at 3.4 years instead of at 1.3 years. Means information which you get in extra years is not really captured by Kaplan-Meier in the sense that your survival curve, because it has assumed that everybody is starting at the same time, will become very thin towards the end. I think what we need to know as clinician is we should know the assumptions of survival curve and some limitations, and certainly not extrapolate beyond the curve. Apart from this, it's very easy if you know how to construct the table, and then after that, of course, once the table is there, very easy to create the graph. I think we will end there. If somebody wants to read more, I will share these references to you, and you can have little more in-depth analysis. Thank you very much. Any question?
Sir, most of the time I have seen that Kaplan-Meier curve for survival analysis are being done in observational studies.
No, not necessary. In many, most randomized trials are giving you a survival curve if there is an event and time is important. So you will get in observational studies like cohort studies, not in case control studies, cohort studies, and also randomized trials, because randomized trials are also a type of cohort study.
And if there are so many comorbidity, if suppose that if we want to predict that, can we use it?
I'm not sure I'm getting your question, but if you are asking whether prediction can be made on the basis of survival curve, I would say yes, it can be done. You can enter predictors in Cox model and find out which predictors are important. And also you can develop a scoring system by which you can predict survival of a patient, or that survival, by that I mean that patient not having event.
No,
Right.
sir, Dr. Jayaprakash is asking about multiple. I think it's a confusion, like if you are assessing stroke, myocardial infarction, can all
Yes.
these be created as events, or should we only focus on one type of event?
You mean if people are having multiple events, then what do we do? Right?
Yeah, definitely, sir.
Yeah. So if event of interest is one, but a person is susceptible to or vulnerable to or at risk of another event, that event is called competing event, right? Competing event. So competing event may require censoring of that person. But when there are too many competing events, then as you can see, some of the assumptions become untrue, which I told you that if more than 50% people are censored, then you don't have valid Kaplan-Meier curve. So that becomes a problem. In that case, there is different type of modeling which is done, and competing risk analysis itself is a big chapter which we will not go into. But suffice it to say that yes, if there is one event which is not of interest but occurs, that is the time when patients are censored.
Okay. Thank you, sir.
Okay, so I think there are no more questions. So
Just one more question.
yes,
One
yes.
question is there in the chat, sir.
I can't, that is the problem. Na? I can't see the chat. I can't see. Now I can see the chat. Yes. If the number at risk are not mentioned in curve, can we interpret? It is a bad practice. That means it is a poorly written paper. And I would think that you have to be very careful when you are reading such a paper which doesn't give number at risk in near the bottom of the curve. But yes, if you are careful, you can certainly have some interpretation of that. I don't know whether if there are any other.
Someone,
Sunil Narayan has a question.
Another question, sir.
Yes, Dr. Nayak.
If you have a sample of patients whom we have followed up and we have the follow-up data with follow-up fixed at certain points of time and all those follow-ups carried out for a sufficient number of patients, then suppose we had missed the certain follow-ups and lost some follow-up values. Is there a role for the survival curves to predict those values at a fixed point of lost follow-up? I mean, the not lost follow-up, but missed follow-up.
Missed follow-up. Missed follow-up means there is missing data.
Yes.
And there are many methods of what is called imputation of missing data. And what does it involve is most of the imputation methods use some form of regression. And someday we will have discussion on regression. But what they do is that based on some of the characteristic of the patient who missed that visit and comparing it with other patients who did not miss the visit, the computer or the regression method predicts what would have happened at that time. So it will impute the value which is missing because patient did not come for follow-up at that time. And that is done by a kind of, it makes an equation, then predicts, okay, what might have happened? Yes, this might have happened. No imputation method is immune from problems. And where my friend Gordon Guide says imputation means making up data. So the best solution is don't have missing data. But certainly many authors have this problem and they impute and they do the analysis, which is obviously accepted by journals. That's why they publish. So you can use some imputation method. Some very simple imputation method is if people don't come for follow-up after 3 follow-ups and you had 5 follow-up, then last observation carried forward is another one way of imputation method. Not very good, but that is what people do.
Sir, last question I would like to ask. Sir, Dr. Jayaprakash here, sir. Sir,
Yes.
if there is quantitative data, then what we should prefer?
Quantitative data, by that you mean it's not an event.
Yeah.
It's not an event, right?
Yeah.
If this is not
But
an
both
event,
the-
then survival analysis is not survival analysis does not apply. It applies only if it is dichotomous type of outcome, which is like an event, and if it is like blood sugar or high blood pressure or hemoglobin A1C, something like this, which are called quantitative or continuous variable, survival analysis doesn't apply.
Okay, thank you.
Okay, so thank you very much. I think we have finished right on time at 9 o'clock in spite of difficulty in the beginning. And next time maybe we'll take up hazard ratio.
Sir, actually, I had a question. It was not clear to me how we can use it in educational designs, like this pass-fail This is a dichotomous variable. So we
Yes,
can
yes.
use it as survival rate,
Yes.
survival analysis, or risk analysis.
Yeah, so some people like they have used it for different purposes, of course, because all students take exam on the same day and decision is made on the same day. So it is not variable length of follow up. That is why it's not commonly used. But if you are talking about completion of thesis, then you know that students who enter PhD, somebody will complete thesis in 3 years, somebody will complete in 4 years, somebody will complete in 5 years. So time to completion of thesis will be a very good survival analysis. The other thing people do is like they do for publication. Everybody gets ethics approval. So ethics approval is the date on which you can start and see when do they publish. So people have done this. What is the rate of survival publication or survival up to publication? Many people don't complete their study. Many people complete but they don't write. So they have done survival analysis on that. They have also done survival analysis on, for example, when do concepts change? So they have said, look here, what is the period of survival of a hypothesis? So some hypothesis which may be in the beginning, and as time progresses, it changes. So how
It is
long does
challenged.
hypothesis survive? So survival of hypothesis has been used, has used this survival analysis and looks very good. The other way survival analysis is done is students are asked in a classroom, how attentive are you? Let's say, so initially 100% will be attentive. Then if they are reporting honestly, they will tell you, some people will say, now I am 80% attentive, now I am 60%. So some students were asked to write every 5 minutes how attentive they are. And then
Yes.
then after dichotomizing it, that means attention which is less than, let's say, 50% is no attention or not useful attention. Then time to reach 50% has been analyzed by survival analysis. So
Yes.
that lot of such questions do come in education also. You can use survival analysis.
Yes, sir. And paper, this presentation in the conference, then coming to publication,
Yes,
can
yes.
also be done, right?
Yeah. From abstract to full paper,
Yes.
people have done this type of analysis, publication to full paper. So abstract is published in conference. Many people don't survive up to full paper, many abstracts, and some who survive, they take variable length of time before full paper is published. You can also do survival analysis for people who register for meta-analysis and see length of time before it gets published. A lot of things can be used, done in field of, you are talking about nowadays interestable professional activity, and people from novice and advanced beginner, they become sort of competent, and sometimes even beyond competence, they become expert and proficient and all that. So time to reach competence is something which you can analyze by survival analysis.
Yes.
So a lot of things can be done. Yeah, so